Ladies and gentlemen, let me start this session. And the first speaker will be Ken Binmoeller from San Francisco, California Pacific Medical Center. It's a great pleasure for me that he is here. I have met him more than 25 years in Nipsoe-Hendra University Eppendorf Clinicum, and I think that all those who undergo training at this university are on the endoscopic heaven as stars, and I think that that's simply true for Ken. And he's an inventor of lumen-apposing stent. And Ken, microphone is yours.
Thank you so much, Stan. Well, it certainly made me feel a bit aged with the 25 years. Time certainly flies by fast when you're having fun. And I certainly have had so much fun in this truly fast-moving area of interventional endoscopy that is organ preserving. And the story of LAMS is about organ preservation. In this talk, I'm going to share some tips, tricks, and pitfalls. In terms of disclosures, I don't have any financial conflict of interest, but I am the proud parent of the Axios LAMS and delivery system. So my first tip is to know your LAMS. In the United States, we only have the Axios stent available, so my personal experience is limited to that stent. I believe in Europe you have the Spaxis. I don't know about any of these other stents. I believe only the Axios and the Spaxis are truly lumen-apposing stents or would qualify as that. The Nagi stent, I did some work with Anthony Teo from Hong Kong earlier, and we tested in benchtop studies the pull-out strength of the various stents, and the Nagi stent did not have the pull-out strength that Axios and Spaxis has. I'm not familiar with these stents. This plumber stent does look a little bit like the Axios stent. Whichever stent it is that you use, I strongly recommend that you deconstruct it, and I'm going to do that with the Axios with you today. But you need to understand how these stents work because there's so little room for error when you're creating a transluminal conduit. What is definitely unique about the Axios stent is the delivery system. It is endoscopist controlled. Really not different from an FNA needle. It is luer locked to the working channel, as you see here, something that we're all comfortable with as endosonographers. It is a one operator, one hand, one device, and one puncture system. Not necessarily one step. There are actually 4 steps that you'll see on the handle, but it certainly qualifies as a one device. Now, considerable time and ingenuity went into the development of the Axios handle. And if I think back, this is some 15 years when we developed the first version. You can see the 3D printed version at Exlumina where this was developed. And its current form now commercialized by Boston Scientific. They look practically identical, so clearly the handle has withstood the test of time. So let's deconstruct the handle. It's so important that you understand these components for safe deployment. So firstly, there are 2 hubs. There's a black and a gray hub. You can see the black hub here, the gray hub here. The black hub advances and retracts the sheath. But it's important that you understand that this occurs only when the black hub is coupled to the gray hub. And it's coupled to the gray hub here with this safety pin. So from the operator standpoint, this black hub is advancing and retracting the sheath. And it's the gray hub that deploys the flanges. But if you deconstruct it, you will see that the black hub actually just advances and retracts the inner catheter. This inner catheter is attached to the nose cone at the very tip, and there is this tray here that houses the LAMS, the axial stent, and it is compressed by the sheath. So the sheath is what you retract to deploy the stent. Now, the other way you could deploy the stent is to push this inner catheter out from the sheath. If you immobilize the sheath, you can use the push technique to deploy the stent. But after considering the various options, we decided back then at Lumina to design this around the pull technique, meaning we're just pulling the sheath back to deploy the stent. There are 2 locks and a yellow safety. The locks are very important that you always pay attention to them. There's a black hub lock here and there is a gray hub lock here. So the black hub lock is not on the black hub itself, it is below, but it will lock the black hub in position. And there are the 4 steps, which are actually written right on the handle. So if you're ever flustered, you can just take a glance at those 4 directions here. So you can see 1, advancing the black hub forward to puncture. Then number 2 up here is retracting the gray hub up here to deploy the distal flange. Then to retract the black hub again. Number 3 here to snug up against the wall. And then the final step is here to retract the gray hub again to deploy the proximal flange. So the locks are key to safe deployment. You are always alternating lock and unlocked. The gray lock here couples the sheath and the inner catheter. So I can't emphasize that enough. These 2 need to be connected or coupled to work as one unit. And that's why we have this safety pin here, so that the default is to be coupled. So that is something that will never be forgotten. You have to actively remove that yellow pin to decouple the gray and the black hub. So it allows the black hub to advance the sheath as a unit, and it allows the black hub to retract the deployed distal flange to the wall. You're using it like a retractor. You're pulling it up. The black lock here is what prevents movement of the inner catheter, and this is what is done during sheath retraction when you deploy the flanges to prevent that inner catheter from moving. Now, the distal and proximal flanges are released completely independent of one another. That is critical because there is no room for error. So it's done in 2 stages. Stage 1 is releasing the distal flange in the target lumen. So this is the number 2 where you're pulling back to number 2, and you can see pulling this gray hub up, number 2 deploys the distal flange. There is an auto lock click. You hear it. It's audible so that you know that now the gray hub has locked. You don't have to actively lock that. It does it on its own. In stage 2, we release the proximal flange in the bowel lumen. So this is step number 4 here. Pulling back, the gray hub releases the proximal flange in the bowel. Now, we do an intermediate step by deploying it in the working channel, but the intent is deployed in the bowel afterwards by pushing that proximal flange out. But don't forget to always snug up. That's step number 3 here. Before proximal flange release, you need to be sure that that distal flange is up against the wall. If you are ever lost, just look for the black band marker. We created this black band marker for all imaging modalities. So first, on endoscopy, you actually see this black band here. That black band is where the sheath ends. So you know when to start deployment of your proximal flange. You can also see this black band on ultrasound. The engineers created this intentionally by using a different material so that on ultrasound it appears like a black gap. So this is the very tip, the nose cone itself, and this is the sheath part, so you know where the end of the sheath is. So you can just use the ultrasound, look carefully, you will see the black band. And If you have fluoroscopy or need to use fluoroscopy, you can see that black band as a radiopaque marker at the tip. So you have different ways to confirm exactly where the end of your sheath is, because you never want to deploy that distal flange outside of your target lumen. You don't want to deploy it in the peritoneal space, for example. Tip number 2, know your target. Know the dimensions, know the contents, and interrogate the interposed tissue. So let's start first with the dimensions. You need to know the minimum cross diameter A and the minimum long diameter B. So cross and long. That long diameter here is the trajectory of your puncture path. The minimum cross diameter must be greater than the flange diameter. So whatever size lambs you pick will determine the flange diameter. And the minimum long diameter here must be greater than the runway needed to deploy the distal flange in the target lumen. So how do we determine the flange diameter? We know the lumen diameter. It comes in sizes starting with 6 millimeters all the way up to 20 millimeters. And as a rule, you can just double the lumen diameter, and that gives you the flange diameter. But in fact, in reality, it is less than double for both extremes. For a 20, the flange diameter is about 30. So you need to have 15 millimeters on both sides of your puncture to be sure that you are placing the flange securely inside of your target and that there are no interposed vessels along that surface area. The runway is very important. It is the space needed for complete distal flange deployment. If you are using a 10 millimeter lambs, then you need 32 millimeters of runway space. Here you can see 32 millimeters. Here it's upside down, but this is 32 millimeters that we have pulled the gray hub back to level 2 to deploy the distal flange. If you're draining the bile duct, we typically use either a 6 or an 8, but if you start with a 6, the smallest, you need a runway of 20 millimeters, 2 centimeters. That means your bile duct needs to be dilated around 2 centimeters if you want to be confident that you're deploying that distal flange completely within the bile duct lumen. That is why for the bile duct we often have to use the push technique to place it over a guide wire. If you use a 20 millimeter lambs, for example, for a gastroenterostomy, you need a runway of almost double, 4 centimeters. So that's why you need to measure that out and be confident that you can completely deploy that distal flange in the lumen. So the long diameter may limit the lamb size that you can use. Target contents. You need to have a sufficient pocket of fluid for distal flange deployment. You must avoid thermal contact with any solid content, especially if it's shadowing. That shadowing means calcium content. You must select a lamb size that is proportionate to the content. So if you're draining a wand, I always use a 20 millimeter. You want to have the largest diameter possible. For the gallbladder, if you have stones, you may want them to spontaneously migrate or to be able to go inside the gallbladder later and do lithotripsy, so you need a 15 millimeter lambs. If you want to optimize your target, it's easy to do, just pre-infuse saline. But there are a few things you need to pay attention to. You must prime your 19 gauge FNA needle with saline. You never want to inject gas into your target because that creates acoustic artifact. So you can see here the syringe is attached to the FNA needle. You hook up your needle then to the water pump after you enter. So here you see the water pump in the second step here attached to the hub of the FNA needle. And then you infuse saline until the desired target size. So here you can see a contracted gallbladder, and we filled this up then with saline using a 19 gauge needle, and that gave us enough room to then deploy a 10 millimeter axios. This was just for drainage of the gallbladder. There were no stones, hence we just used a 10 millimeter axios. interrogate the interposed tissue, looking at the distance, whether there are any vessels present, and for adherence. And here, when you see a fat plane like this, that is a sign that there is poor adherence. So it's only when you don't see that fat plane that you may have an adherent cyst. This is important because I'm not saying you always have to use an Axios or a LAMS to drain pseudocysts. You can use plastic stents, but if you use plastic stents using the Seldinger technique, you should be confident that there is adequate adherence. Know your cautery. Tip number 3. Use pure cutting current. You can increase the voltage for difficult penetration. So for example, if the wall is very scarred, you may want to up the voltage, for example, from 100 watts to 120 watts. Advance the catheter into the target slowly with steady pressure. I call it the 3 S's: slow, steady, and smooth. This is not an FNA. You're not thrusting this into your target. You're very slowly advancing it and letting the diathermy do the puncture, not the mechanical force of advancement. Stop if you see any interposed gas that impairs your ultrasound view. Just wait until the view clears up. Look for the boiling sign. That's when you see some bubbles. It's the diathermy effect. That indicates you have entered your target. And as soon as you have entered your target, stop the advancement. Have your assistant disconnect the cable so that you don't accidentally perforate the opposite wall. And this is what can happen. It happened to me. For gallbladder drainage, I perforated the opposite wall, and fortunately I was able to close it with a clip. But this is the sort of thing you must pay attention to. Tip number 4 is know when to preload a guide wire. Now, firstly, I would say anyone starting this procedure should preload with the guide wire. It is a safety net to retain access. If anything goes wrong, you have your safety net in place. You can always remove the Axios and you can place a second stent, maybe a second Axios, maybe with a longer saddle. If you used a 10, use a 15, or you can use a fully covered SEMS. By placing the guide wire, you can deflect the nose cone away from the opposite wall. So this is why for the bile duct, I will always place a guide wire so that I know I am targeting the hilum, I'm oriented towards the hilum, and I can deflect the nose cone away from the opposite wall. Also to prevent accidental injury to that opposite wall. So we can orient the direction of that distal flange deployment not only for bile duct but also for the edge procedure where we're doing a gastrogastrostomy. You want to be sure that your endoscope, as it passes into the native stomach, that it is oriented towards the pylorus and not the fundus. So here you can see the guide wire at the very tip here. I have my assistant use a magic marker so that we know that the guide wire remains at the very tip. So you don't want to accidentally have that wire pulled too far back or going too far forward. Tip number 5, and now we're getting to the most important tip. You must think about your ability to manage a maldeployment. You must have all of the instruments available to you in the event of a maldeployment. There are 3 types of maldeployment, 1, 2, and 3. These were first described for gastroenterostomy, where maldeployment was very common. Type 1 is about 2/3 of the cases, the majority, and I differentiate 2 types, type 1A and type 1B. 1A is when the proximal flange has not yet deployed. You actually have the ability to resheath. I can show you how that can be done, but that is possible. Type 1B is where the proximal flange is deployed. There you have to remove your LAMS. Now you can repuncture after that. I will always place a guide wire so I know where the hole is so that I can close it afterwards. For type 2, that's in about a third of the cases. Again, I differentiate two types. One is where you have a guide wire in place so you can insert a second stent. Again, that can be a longer LAMS, 10 switched out for a 15 millimeter, or a SEMS, a fully covered SEMS. Type 2B is where you have no guide wire, so you have to remove the LAMS, and the patient may require surgery, although very often this will not result in any persistent injury because the hole closes on its own. But the hole, of course, will not close on its own with a type 3. Here, the contents of the small bowel are freely draining into the peritoneal space. These are the patients that end up having to go to surgery. Type 3 can easily occur if you're not paying attention to the deployment of that proximal flange. And sometimes that proximal flange, after it's compressed in the working channel, as you push it out, it doesn't open up right away. So that's how you can accidentally push it in. And this is a video of a case a colleague of mine did in my unit. He's learning this, and he learned from this mistake. You can see he snugged up very nicely. He's ready now to switch to the endoscopic view. But when he pushed out, he did that too rapidly without waiting to see that proximal flange open up, and he pushed that proximal flange through the stomach wall into the peritoneal space. And this patient had to go to surgery because you have drainage freely into the peritoneal space. You must have devices to close a hole. I prefer to use the over-the-scope clamp, and this is because it provides the most secure closure. But these holes can be hard to identify if you don't mark them immediately. So I always place a guide wire through there to be sure I can identify it. So I'm going to summarize with these 5 golden tips. Know your LAMS. Know the target, know the dimensions, know the contents, know the interposed tissue, know your cautery, check the settings, know when to start and stop cautery, know when to preload a guide wire. In the beginning, I would always do that as a safety net, and know how to manage maldeployment. Thank you.